Good afternoon. My name is Angela Kaida. I'm an associate professor and Canada Research Chair in the Faculty of Health Sciences at Simon Fraser University. I'm honored to present to you today on behalf of our co-authorship team, a talk titled Intention to Vaccinate and Key Population Membership for COVID-19 Immunization by HIV Status among a provincial sample of women and gender non-binary individuals in BC, Canada. I am honored to live, work, learn, and play on the traditional, ancestral, and unceded territory of the Coast Salish peoples, and specifically the shared traditional territories of the Musqueam, Squamish, and Tsleil-Waututh nations. I'll begin by saying that I have no conflicts of interest to declare. So let's begin. Among people living with HIV, the risks of SARS-CoV-2 infection and outcome severity may be driven by social disparities and comorbidities. The National Advisory Committee on Immunization considers such disparities in prioritizing key populations for early COVID-19 immunization. And while relatively few people living with HIV have participated in COVID-19 vaccine trials, the available data suggests that the vaccines are effective and that there are no unusual safety concerns among people with well-controlled HIV infection. Accordingly, the BC CFE's Committee for Drug Evaluation and Therapy recommends that people living with HIV aged 18 years or older may be vaccinated for COVID-19 using the mRNA vaccines if they meet current public health criteria for priority groups and if they have no other contraindications. And currently, people living with HIV are not considered a priority population in the BC immunization plan. However, many do belong to other communities prioritized for vaccine receipt. So the success of a COVID-19 vaccine rollout is of course contingent on vaccine uptake, and a lack of confidence in vaccines, vaccine uncertainty, and medical mistrust may influence vaccine uptake and contribute to further perpetuating COVID-19 inequities. So using population-based survey data from a BC-based sample of women and gender non-binary individuals and grounded in the theory of planned behavior, the objectives of this study were: one, to estimate and compare intention to receive the COVID-19 vaccine by HIV status, and two, to measure and compare the distribution of constructs of vaccine confidence, vaccine risk, vaccine attitudes, perceived behavioral control, and direct and indirect social norms by HIV status. So our participants were enrolled in the COVID-19 response study, or the rapid evidence study of a provincial population-based cohort for gender and sex, which is led by the Women's Health Research Institute. The participant pool were those aged 25 to 69 years, and were drawn from community and hospital-based research studies of participants who had indicated a willingness to be recontacted for future research. And this included participants of the CHIWOS and KARMA cohort studies of women living with HIV in BC. Participants were recruited via email invitation with PRA, or Peer Research Associate led enhanced recruitment strategies for women living with HIV, and invited to participate in an online baseline survey of COVID-19 impacts hosted through REDCap. This analysis is restricted to women and gender non-binary respondents. The primary outcome was vaccine intention, which we measured using the question: if a COVID-19 vaccine were to become available to the public and recommended for you, how likely are you to receive it? And the responses were dichotomized as likely versus unlikely. We used multivariable logistic regression to assess the independent effect of HIV status on vaccine intention. And then we conducted bivariable analyses to examine associations with psychological constructs, including the two-factor WHO vaccine hesitancy scale, as well as several constructs of the theory of planned behavior specified for the COVID-19 vaccine. For the results, so between August 20th of 2020 and March 1st of 2021, 6,518 people responded to the survey. Of those, 5,588 identified as women or gender non-binary individuals. Of those, 98.8% were not living with HIV, and 69 or 1.2% were living with HIV. And this table 1 shows the baseline characteristics of the study sample by HIV status. So you can see here several differences in the samples by HIV. But to start with, there was no significant difference in the mean age of participants by HIV status. There was also no significant difference in whether or not participants were essential workers. However, we do see here that participants living with HIV had more gender diversity, as well as more ethnic diversity relative to those not living with HIV. In terms of education and household income, we had a lower proportion of participants who reported having more than a high school education among those living with HIV, as well as a higher proportion who reported a household income of less than $20,000 per year. With respect to chronic health conditions, and this excluded HIV, we saw that a significantly higher proportion of those living with HIV reported 1 or 2 or more chronic health conditions relative to those not living with HIV. And then of those living with HIV, the median years living with HIV was 20.5. 79.7% were currently on antiretroviral treatment, and 73.9% reported having an undetectable viral load. We also found that 58.6% reported being more or much more fearful of acquiring COVID-19 because of their HIV status. Okay, vaccine intention. We found that 65.2% of participants living with HIV reported being likely to intend to get the COVID-19 vaccine. And this was significantly lower than the proportion among those not living with HIV, where 79.6% reported an intention to get the COVID-19 vaccine. And when we looked at this data as an unadjusted odds ratio, we saw that there was a significantly lower odds of reporting an intention to vaccinate among those living with HIV of 0.49. However, in adjusted analyses, we found no significant difference in the odds of reporting an intention to vaccinate among those living with HIV compared with those not living with HIV. So an adjusted odds ratio of 0.82 with a 95% confidence interval of 0.46 to 1.50. And so the difference that we saw in the unadjusted analyses was explained by differences in the distribution of ethnicity, household income, and education. So now I'd like to show you some of the data comparing the psychological constructs. So first, we examined the 7-item WHO vaccine confidence scale, where we assessed the proportion who reported agreeing or strongly agreeing to 7 questions about general vaccine confidence, including, for example, the information I receive about vaccines from the vaccination program is reliable and trustworthy. Across all 7 items, participants living with HIV reported significantly lower vaccine confidence. We then examined the 2-item WHO vaccine risk scale, which asks about concerns regarding potential serious adverse effects of vaccines and about newer vaccines in general. But here we found no significant differences in concerns about vaccine risks by HIV status. We then examined attitudes towards the COVID-19 vaccine specifically, using an 8-item scale, which asked participants about whether a COVID-19 vaccine would be safe, for example, would be effective at preventing COVID-19, would be beneficial for the health of my community. And we found other items. And we found that participants living with HIV expressed significantly less positive attitudes towards the COVID-19 vaccine, with one exception. Down here, you can see there was no difference in respondents reporting that COVID-19 is a serious illness, very similar proportions by HIV status. We assessed perceived behavioral control, the degree of control that participants felt to receive the COVID-19 vaccine if they wanted to, and found no significant differences by HIV status. And then finally, we assessed the influence of direct and indirect social norms on influencing COVID-19 vaccine uptake. And we found that participants living with HIV were significantly less likely to be influenced by direct social norms, including, for example, feeling under social pressure to receive a COVID-19 vaccine. Participants living with HIV were also significantly less likely to be influenced by indirect social norms, including by the advice of the BC provincial health officer, by friends, by family. They were, however, equally likely to be influenced by the advice of family doctors or their primary healthcare providers regarding uptake of the COVID-19 vaccine. And in bivariable analyses restricted to participants living with HIV, we found that these constructs were significantly associated with an intention to vaccinate. Those with lower vaccine confidence in general were significantly less likely to report an intention to receive the COVID-19 vaccine, you can see here, while those with more positive attitudes to the vaccine, who were influenced by direct social norms and by the advice of family doctors, the provincial health officer, friends, and family were all significantly more likely to report an intention to receive the COVID-19 vaccine. So in summary, HIV status was not associated with COVID-19 vaccine intention in adjusted analyses. However, only 2/3 of participants living with HIV reported intending to receive the vaccine if it's recommended, significantly lower than participants not living with HIV. We also found that that the psychological constructs, the distribution of the psychological constructs differed significantly by HIV status. And among participants living with HIV, intention to receive the vaccine was significantly higher among those who expressed vaccine confidence, positive attitudes towards the vaccine, and who were more strongly influenced by direct and indirect social norms. We did not see any associations with vaccine risks or perceived behavioral control, which is actually consistent with findings from the overall response study sample. So where to? So I think the first discussion point here is our need to embrace GIPA and MIWA principles of community involvement and engagement in the COVID-19 vaccine response. We need to work with women living with HIV to specifically engage family doctors or primary healthcare providers, provincial officers, peers, to communicate the messages to influence vaccine confidence among women and gender non-binary individuals living with HIV. We must do this work to build vaccine confidence, address vaccine concerns, support informed vaccination decision-making, address lingering medical mistrust concerns, and overall this effort to promote COVID-19 vaccine uptake. Just like to end by thanking the COVID-19 response study team and all of our participants.